The blue line is, as you can assume, this is marking. So now we are bringing the farther end, that is the 12 o'clock suture beneath the arterial wall. So it rotates this way, and you can easily. So the 6 o'clock goes to 12 o'clock, 12 o'clock goes to the 6 o'clock, and the posterior wall of the artery is basically exposed. Hello everyone, welcome back. So this will be second part of the interrupted arterial anastomosis, and in this short video we will discuss theory part briefly, followed by demonstration of how to flip the artery in difficult situations. Please read the detailed disclaimer and description, and these videos are meant for education and information purpose only. For an exclusive and early access to our premium high definition content, you can download our app or join the channel membership. The link for everything is given in the description of this video. So I will quickly run through the points which we have already discussed in our previous video, that was part 1 of the interrupted arterial anastomosis, in which we covered theoretically. So it is highly desired that viewers watch previous video, which is available as a free video on our app and on our YouTube channel. We discuss different type of the techniques, the relevant literature, what are the pros and cons of one technique over the other. So I'm quickly going through these slides. If you want, you can pause the video and go through these slides, or watch our previous video in which we have discussed everything in detail. So let's start with this part, that is artery flip technique for vascular anastomosis. So friends, some teachers, I have also learned this technique from one of my teacher have described this artery flip technique while rotating the posterior wall by 180 degree to basically to aim is to suture the posterior wall under vision, and this is implied when the larger artery is there more than 4 mm and when there is space and tissue tolerance. The disadvantage of this technique is that you cannot use it in smaller vessels. This can lead to the trauma and intimal damage. So this should be used only in difficult situation when you are finding it difficult to anastomose the posterior wall. And in case of the smaller diameter vessels, it will be wiser to sew the posterior wall under vision under magnification of loop or microscope. Do remember that don't use this technique in smaller vessels and only use when it is a larger vessel like more than 4 mm. So these are the do's for this technique: that mobilize vessel and adequately before flipping, place stay suture before rotation for control, handle vessel as atraumatically, hold adventitia, never hold the intima, and use for larger vessels only, and flush the artery with Hepanic's line before tying the final knot. And always mark the interior wall with the help of some marking pen, otherwise you may lose the orientation while suturing. Always take the corner stitch first, and do not use excessive traction. So the whole aim of this technique is that flipping the artery by 180 degree, you can suture the posterior wall under vision, so it makes the invisible posterior wall visible for suturing. So now let's see how to do it on a PTFE graft. So about the instrumentation and these gastroviso I've already covered. So we start with the suture at the farther end, that will be 12 o'clock location. So I take inside out on both the sides, and as I have already discussed, keep the distance from the margin approximately 2 mm. Not too much distance can lead to the inversion, and too less can lead to the cut through. So both side I come from inside out. So this will be 6 o'clock suture. Always hold the adventitia, never hold the intima. So here I have relatively fixed the artery, so the manipulation may be difficult, and I'm doing it alone, so there is no expert assistance available. In real life, you will have good assistance and you may be able to do it with little bit of more ease. So trick is that we don't tie the corner suture. This will be 12 o'clock suture we have already taken, and we hold it with a rubber shot, fine mosquito forceps with the rubber tubing applied at the end. Otherwise, it can break. So then we will hold it in one place, and it should be under little bit of tension so that the suture end remain aligned. The marking of the arterial wall, anterior arterial wall, we have already done. So I'm another now taking the 6 o'clock, the end towards the surgeon. So here I'm coming outside in the basically proximal or afferent loop, and inside out on the efferent loop. Aim is to keep the knots outside the lumen vessel, and so here just to save the suture, I'm taking it. Otherwise, in a real life scenario, it has always to be a double arm suture, and you will always come inside out on both the end. And so I have taken this 6 o'clock suture. Again, I am not applying knots here, and I will keep it as such so that they keep aligned. The blue line is, as you can assume, this is marking. So now we are bringing the farther end, that is the 12 o'clock suture beneath the arterial wall. So it rotates this way, and you can easily, so the 6 o'clock goes to 12 o'clock, 12 o'clock goes to the 6 o'clock, and the posterior wall of the artery is basically exposed. So in the last, we will tie the, so this will be the basically anastomosis segment I have cut to demonstrate. So all the knots are outside, and this will beautifully heal without much. The space is because I have not taken all the sutures. Basically, this is demo video. In real life, you will take sutures at closer space. So, posterior wall suturing challenges are: there is a limited visibility, difficult access, awkward angles, risk of back wall stitch, lumen narrowing, higher chance of internal injury, and prolonged, basically, clamp time. So this technique is basically the advantage is that you convert the posterior wall to anterior. There is a better visibility, needle control, reduce risk of back wall stitch, faster, safe suturing, especially useful in trauma setting. Keep practicing, friends, for the sake of your patient, and practice will make you perfect, and you will have an excellent recovery. These points I have already covered, that the intersuture distance is 2 mm, from the margin is 2 to 3 mm. Always use double arm, inside out. If you are using single arm, then basically one has to come outside in the afferent, and inside out on the efferent, basically to avoid the intimal dissections. And these, if you flush the artery with the heparin before applying the last knot, and release the afferent clamp, then apply the last knot so that all the debris and clots are cleared. Unlike veins, artery don't need a growth factor. So I'm quickly rushing through as these points have already been covered. Strip the adventitia for 3 mm, and we will also demonstrate during cadaveric demonstration. So this is a very handy technique when the suture margins are compromised. So with that, we have reached the end of this video. I hope you will find this technique useful, and in difficult situations when you are alone, and then you will basically be able to do better anastomosis. So these are some of the thumbnails. The videos we have already uploaded. Viewers can watch all those videos on our YouTube channel and on our app. So thank you very much, friends. Happy learning. Thank you very much.